Hi, very good morning. So in this live session, we'll discuss multiple choice questions pertaining to oral radiology, right? Multiple choice questions pertaining to. So we'll start with the first question. You have a patient who is extremely concerned about radiation exposure. Okay, let me just post it first. Good morning, Bernice and Neetu. Hi. Hi, Preeti. So here we go. The first question. You have a patient who is extremely concerned about radiation exposure that he is going to receive when he gets an intraoral radiograph taken. You let him know that if he wants the least exposure, then you will use the following technique. And the options include. Good morning, Ashina. Yeah. Option A, distal radiography. Option B, E-speed films. Option C, F-speed films. And option D, panoramic instead of full mouth series. So you have a patient who is extremely concerned about radiation exposure he will receive when he gets intraoral radiograph taken. You let him know that if he wants the least exposure, then you will use option A, digital radiography. Option B, E-speed films. Option C, F-speed films. And option D, panoramic instead of full mouth series. So that's the first question for today. So Neetu, you say panoramic instead of full mouth series. Ashina, you say D. Preeti says yeah. Okay. See, just keep this in mind that panoramic radiograph. If you want any specific area of a tooth to be observed, then panoramic radiograph will not be of much of diagnostic use because the areas are not clear and they will not have much clarity over a particular area if you're going for a panoramic radiograph rather than an IOP or bite wing. Because in most of the radiographs which we need in case of operative dentistry or endodontics or periodontics, it's mostly IOPA or bite wing, isn't it? So panoramic radiograph cannot be a replacement for traditional IOPA or a bite wing or even occlusal radiograph for that matter. So if the patient is really concerned about the amount of exposure he is going to get, by the way, if you compare digital radiography, E-speed films and F-speed films, you'll have in various conventional radiographic techniques. Coming to films, E-speed films and F-speed films, they have comparatively, they require less exposure than the predecessors. But if you compare digital radiography with a conventional kind of radiography, then the amount of exposure which the patient is going to get is drastically reduces. For example, digital radiography decreases the exposure time around 50 to 80% compared to D-speed film or E-speed film, and decreases the exposure by about 50% compared to F-speed film. Right, so digital radiography is the one where there is drastic decrease in the amount of exposure which the patient is going to get. Right, so among the given options, digital radiography is the more appropriate answer, right? So panoramic radiograph cannot be a replacement for traditional radiographic techniques like intraoral or bite wing as we discussed now, right? So one of the positive features of digital radiography is that it requires very less radiation than conventional radiography, because the sensor which we are using in digital radiography, it is very much sensitive. It's very much sensitive to X-rays than the dental film, and the exposure times for digital radiography are from 50 to 80% shorter than E-speed film and about 50% shorter than F-speed film. This translates into less radiation exposure for the patient. If you, you can just note down this particular point. The exposure time for digital radiography is 50 to 80% shorter than those for E-speed film, and the exposure time is 50% shorter than those of F-speed film, right? So this is very much important, right? You can just make a note of this point, and I hope it's clear, right? Hi Bir, Ramesh and Swapnil, a very good morning. Okay. So to conclude, you have a patient who is extremely concerned about radiation exposure he will receive when he gets intraoral radiographs taken. You let him know that if he wants the least exposure, then you will use digital radiography rather than traditional or conventional radiographic techniques or extraoral or panoramic kind of radiographic techniques. Right? Hope it's clear. Now let's move on to the next question. So this is comparatively easy. Let's see how many of you can answer it accurately. So the question is, which of the following allows the most radiation to penetrate? Options include amalgam, enamel, dentin, maxillary sinus space. So here you go. Which of the following allows most radiation to penetrate? Amalgam, enamel, dentin, maxillary sinus space. Okay. So, yeah, it's very much clear to all of you, right? Good. So, it is maxillary sinus space, right? So, those structures which are more calcified, they absorb more radiation and they appear as radiopaque structures on an IOP or any conventional or digital radiograph. In contrast, those structures which are least calcified, they allow more radiation to pass through them and they appear more dark or gray in color, right? I hope the concept is clear, because often we tend to get confused like which is radiopaque. We know the structures which are radiopaque and radiolucent, but we need to have the clarity whether that radiopacity or radiolucency is because of more absorption of radiation or because of greater transparency of the given material to that radiation, right? So various radiopaque structures are those where the radiation penetration is very much less. For example, enamel, dentin, bone, metals, etc. Right? And radiopaque structures, as you all know, they appear white on a processed film. And radiolucent structures are those which allow radiation to pass through them and they absorb very little amount of radiation. And more radiation penetrates the structure, as in case of pulp, as in case of maxillary sinus, to reach the film. And radiolucent structures appear gray to black on a processed film, right? So less dense materials, including soft tissue and air space, appear to be more radiolucent, right? So it's clear. So which of the following allows most radiation to penetrate? It's obviously maxillary sinus. And now tell me the order with relevance to other options, like which of the following structures allow least amount of radiation to pass through them, or in other words, which of the following other options, like in amalgam, enamel, dentin, absorb more amount of radiation, or which of the following options among amalgam, enamel, dentin appears to be more radiopaque, right? What would be the order of radiopacity of these structures? So you can have the same stuff in different formats. I mean, they can ask you in different formats, isn't it? So among amalgam, enamel, and dentin, the rest of the options, right? Which is more radiopaque and which is less radiopaque comparatively. Yeah, obviously it's going to be amalgam, right? So amalgam is going to be more radiopaque. Okay. Radiopaque followed by enamel followed by dentin. So enamel is more calcified than dentin, so it appears to be more radiopaque, isn't it? Right. Bingo. Fine. So if I give you few options like periodontal ligament, dentin, enamel, zincoxyreginol, and amalgam, what would be the order of radiopacity from least to most radiopaque structures? I'll just throw you the order in the comments here. You just arrange it and we'll see. Because often we'll have questions pertaining to radiopacity or radiolucency of materials also. So periodontal ligament, space, dentin, enamel, zincoxyreginol, amalgam. By the way, we're going to have some image based questions now. So I'll just project you images through my mobile itself, right? So I'm just giving you some options. Arrange them in an order from starting from the material which is least radiopaque to the material which is most radiopaque. Okay, you have the options here, Neetu. You just go through the options again and then comment. Okay. So you're all starting with PDL space, right? So it is least radiopaque. True. Followed by dentin, followed by enamel. So among zincoxyreginol and amalgam, which is more radiopaque? Okay. So most of you are light. Okay, fine, good. So it is starting with periodontal ligament, followed by dentin, followed by enamel, followed by zincoxyreginol, followed by amalgam. So amalgam would be the most radiopaque material, right? Right. Bingo, good. Thumbs up. Right. So next we'll have a kind of different question. Of course, JAC is radiopaque. Yeah, JAC is radiopaque. But when you compare it with enamel or amalgam, it is less radiopaque. Haven't you seen JAC anytime on a radiograph? Priya? Yeah. It is radiopaque. So JAC powder contains various metal oxides, right? Yeah, silica particle. Silica is okay. You have alumina particles, you have calcium and all, right? So JAC is radiopaque. So you have a next question. Your dental hygienist. Hygienist, NI. Composite is radiolucent. I mean, since it just keep this in mind, Abbas. Composite or any resin for that matter is radiolucent. But since you have some filler particles, it appears comparatively radiopaque, right? Yeah. Resin itself is radiolucent. Uh, we can't call that as radiolucency, Priya, because see, it's all about comparison. Thin line of radiolucency beneath restoration. Which restoration? You just observe JSC. Just Google it. You'll get some pictures. It is. I mean, you can't call it radiolucent. It is radiopaque, but less radiopaque compared to enamel, compared to a zinc phosphate base, compared to amalgam, right? Okay, fine. Right. So your dental hygienist has a patient who states that she needs bite wing X-rays because it has been 6 months since the last films were taken. Your hygienist should respond in which manner listed below. Of course, we don't have the practice of incorporating hygienist here, but abroad, US and all, it's mandatory. I mean, they have a dental hygienist. So option A, option B, then option C, and then option D. Yeah, here you go. Your dental hygienist has a patient who states that she needs a bite wing X-ray because it has been 6 months since the last films were taken. Your hygienist should respond in which manner listed below. Options: option A, agree with the patient. Option B, tell the patient that bite wing X-ray should be taken once a year. Option C, tell the patient that dental X-rays are taken only when needed as judged by each patient's needs. Option D, none of the above. I mean, we're not talking about the scenario here. Here, most often, the patient decides and guides the operator regarding the treatment plan, isn't it? I mean, I'm not talking about dental colleges, I'm talking about the private practice. Because if you take an IOPA or if you take a bite wing, no offense, but you'll get more money, right? So that's how the orientation is here. It's unfortunate, but that's how it's happening, right? So most of you go with C, but few say B, right? Okay. See, patient will have no word, or patient cannot decide like when the radiograph has to be taken. It's up to the operator to decide whether an appropriate radiograph is needed depending upon the patient's needs. Bite wing and all, okay, regular checkup once in a year, that's fine. Regular checkup is fine, but taking a bite wing or radiograph is not mandatory. I mean, it's not mandatory. Only when there is clinically any scenario, or if the patient is symptomatic, only in such cases we go for radiographs, right? And this is, I'm not telling this. These are certain instructions given by ADA as of like when to go for a radiograph, right? So routinely radiographs are not prescribed as per the ADA regulations, right? So option C, tell the patient that dental X-rays are taken only when needed as judged by each patient's needs in accordance to ADA specifications or ADA regulations, right? Yeah, there are some guidelines published by ADA that aid a dentist in prescribing the number, type, and frequency of dental X-rays, right? So option C is the appropriate answer. Right. So now let's have some image-based questions. I'm just trying this new format in live sessions. So I'll just project an image and let's see, how you're going to answer it. So the question is more or less identify the structures to which the arrows are pointing to. I'll see whether we can alter the brightness. Is it clear? Let me just check out. No, the brightness is too much. Yeah, I think it's too bright. Now comparatively, no, I don't think so. It's so clear, right? Let me just decrease the brightness further. Yeah, I think this is comparatively better, right? Okay, fine. I mean, is it clear? Like, just let me know how it is. Yeah, I think it's clear now, right? If I bring it close, I've decreased the brightness also. Yeah. So if you observe the arrows, those they're pointing to, right? Yeah. Yes. Okay, fine. Right. So thank you for the feedback. So we'll try. I mean, we're having some reflection of the table here. So next time onwards, what we'll do is we'll try to place some cloth or something so that, or we'll do it right now. I'll just place a cloth so that we'll not have much reflection. Right, you're saying maxillary tuberosity, right? Most of you? Good. Let's see. Let me just try out once again. Yeah, I think it's clear now, right? Yeah. Okay. So you have that bulbous radiopaque structure distal to the third molar, right? And on first molar, you can see some extensive restoration. Distal to third molar, we have the arrows pointing out towards a very faint radiopaque structure, which is bulbous, right? So, what could that structure be? So that is maxillary tuberosity. Good. So I'll show you a few other pictures along with that. Let's see. So the maxillary tuberosity appears as a radiopaque bulge distal to the third molar region, right? Good. Now we'll proceed with the next one. So let's see how many of you can identify this structure. So you can see again distal to third molar. You have, I mean, those black lines are nothing but arrows. These black lines are arrows. I mean, you have to identify the structure within those black lines or markings. So it is present distal to third molar. It appears as a radiopaque structure which is linear. Right? It's not bulbous as we have seen previously. So what could this structure be? So seriously, how many of you think it's styloid process? So it seems to be like an extension or a process, right? Styloid process is something where you find, I mean, almost here in this area, I mean, in the middle third of skull, if I remember, along this area, you'll find a styloid process. It will not be distal to third molar. I mean, if you remember, in complete denture, when you extend, I mean, what would be the posterior extension of a complete denture? You have this something called as Hamular notch, right? Answer? No, I'm going to give you the answer. That's for sure. Good. Bingo, Ashina. So it is nothing but, no, I mean, you can guess, right? We have the answer. It's Hamulus. It's not notch. Notch appears to be a radiolucent structure. Notch is different, but this is an extension, right? So it's a process. It's a Hamular process. So Hamulus, also known as Hamular process, is a small hook-like projection of bone extending from the medial pterygoid plate of sphenoid bone. It is located posterior to maxillary tuberosity area. Bingo. So you can just have a look at it again. So a Hamulus or a Hamular process is a small hook-like projection of bone extending from the medial pterygoid plate of sphenoid bone. The Hamulus is located posterior to the maxillary tuberosity area. Right? I hope it's clear now. Anyways, well tried, Neetu and Preeti. Now, we'll have another image, a third image for today. Let's see how many of you can identify it accurately. So can you see it now? Yeah, I think you can see the numbers clearly, right? Okay. I'm actually having a mirror-like reflection here. Fine. So identify numbers 1, 2 and 3. Identify the numbers 1, 2 and 3. I think 1 is not so clear, right? Yeah, 1 is not so clear. Okay, 1 second. Let me just, yeah, can you see now? I think 1 will be clear now, right? I mean, it's quite difficult to orient this. Since I'm trying it for the first time, I'll make sure that from next time we'll have better clarity. I'll just try to angulate it in appropriate position. So I think 1 is clear now. So 2 and 3, I think it's all clear. So 1 you can see. See, 1 is pointing out towards an area which seems to be like a junction between a more radiopaque and a less radiopaque structure. So 2 is we have a kind of periapical radiolucency, and 3 seems to be like a radiolucent area in the bone, right? So mandibular bone region, trabecular process. Right. Okay. So 1 is nothing but if you remember, it's a junction between the more radiopaque and less radiopaque structure, right? So 1, it is a CEJ, cemento enamel junction. And 2 is nothing but, I mean, as most of you rightly said, it is, I mean, we don't find any periapical radiolucency or widening of PDL, right? So it's like, I mean, we have to go for tube shift or Clark's technique or Walton's technique to identify that. It's fine. So 2 is ventral foramen. And 3, it is, I mean, do you see a linear radiolucency there? You don't find any linear radiolucency, right? And nerve cannot be seen on a radiograph, right? So you can see we have, wait, let me just show you. So this 1 is something which is present between a more radiopaque crown and less radiopaque root, right? So this is CEJ. So 1 is pointing out towards CEJ. 2 will be your mental foramen. As you all rightly pointed out, it's usually present mesial or distal to the second premolar. And 3, you can see, it all appears to be radiolucent area, right? So mandibular canal would be more linear and narrow, but this is wider. This radiolucency is wider, so it represents submandibular gland fossa, right? Submandibular gland fossa. Right? Hope it's clear. So we'll just stop with these image-based questions, right? And so next time we'll make sure that we have proper projections. We'll plan out well. I think, I hope it's clear, right? All the images. Right. So we'll just move on to the next question. Yeah, we're done with 17. Yeah, just go ahead with the next question. All of the following are radio resistant except all of the following are radio resistant cells except, so we have options: mature bone cells, muscle cells, epithelial cells. So all of the following are radio-resistant cells except mature bone cells, muscle cells, nerve cells, and epithelial cells. So which one is the exception? Just remember the simple concept or logic here is all cells which are having active division or which undergo mitosis actively, they are the cells which are more prone for these effects, radiological effects, right? Radiation related effects. So all those cells which have rapid proliferation or which undergo rapid mitosis, they are more radiosensitive compared to mature cells or those cells which have limited potential to divide. So since mature bone cells are those which do not have any potential to divide further, osteocytes, so they are radio resistant comparatively. Muscles and nerve cells, the same scenario, right? So we don't find much division among them, right? So in epithelial cells there is rapid division, mitosis happening. So these are the cells which are more susceptible for radiation, right? So these are comparatively radiosensitive. So not all cells respond to radiation in the same manner. General, remember that the greater the rate or potential for mitosis, the greater the rate or potential for mitosis, and the more immature the cells and tissues are. These are the two factors. The first thing is the greater the rate or potential for mitosis, and secondly, the more the cells they are immature. If they are more in progenitor stage or if they are more immature, then they are considered to be more radiosensitive. Studies have shown that they are comparatively more radiosensitive than mature cells or those cells which have limited potential to divide, right? So cells that are radiosensitive include blood cells, immature reproductive cells, epithelial cells, and young bone cells, right? Young bone cells. So blood cells, immature reproductive cells, epithelial cells, and young bone cells. And the cells that is most sensitive among all the given options or among all the cells include small lymphocytes. So small lymphocytes, they are considered to be even more sensitive to radiation. Whereas radio-resistant cells are those cells which include bone cells, muscle cells, and nerve cells, as we all are familiar with, right? So just make a note of these points, right? So in general, greater the rate or potential for mitosis and more immature the cells and tissues are, they are more susceptible for radiation injury or radiation effects. Cells that are radiosensitive include blood cells, immature reproductive cells, epithelial cells, young bone cells, and of all the cells, the most radiosensitive or most sensitive to radiation is a small lymphocyte, right? And radioresistant cells include bone cells, muscle cells, and nerve cells. So these are regarding cells. Coming to radioresistant organs and radiosensitive organs. Radiosensitive organs are those which are composed of radiosensitive cells, which include lymphoid tissues, bone marrow, testes, intestines. So if you observe these areas, these are the areas where you find rapidly dividing and proliferating cells which are in immature state, right? So you have lymphoid tissue, you have bone marrow, you have testes, intestines, right? And examples for radioresistant tissues include salivary glands, kidney, liver, muscle, etc. Right? Hope it's clear. So you can just make a note of these radiosensitive cells, radioresistant cells, and also radiosensitive organs and radioresistant organs, because we have lot many questions pertaining to these aspects, right? Of the given options, which is more radiosensitive. They can either ask you a cell or they can even ask you a tissue or organ, right? So this is very much important. Just make a note of these points, right? I hope it's clear. So the question, now it's evident. All of the following are radioresistant except, so it's option D, epithelial cells, which are comparatively more radiosensitive. Now let's move on to the next question. We'll do one thing. These image-based questions and all, we have a lot many image-based questions. We'll discuss that separately in a recorded version, because recorded version will have scope to project the image in a larger manner. So we'll do these image-based questions separately in a recorded format also, right? Here and then 1 or 2 questions in live, I don't think that will be a problem, right? Yeah. Let's have another question. Hi Devil, good morning. Right. The density of a radiograph is influenced by all of the following except. Options include KVP, MA, exposure time, and option D, whether the film is a 1 film packet or a 2 film packet. So here you go. The density of a radiograph is influenced by all of the following except KVP, MA, exposure time, and option D, whether the film is a 1 film packet or a 2 film packet. So KVP is tube voltage, MA is tube current, and then you have exposure time, option D, a 1 film packet or 2 film packet. Okay, and also the relation between tube current, tube voltage, and exposure time to the density of radiograph is quite important, isn't it? So someone, Bernice says KVP, Preeti says exposure time. In fact, if you look at the first 3 options, they are directly proportional to density. Density will increase as tube voltage, tube current, and exposure time are increased, right? So you'll have more number of electrons hitting. If you increase tube current, more number of electrons start entering from the target, right? And if you have more tube potential, electrons with higher energy levels start hitting them. And exposure time, if you increase the exposure time, obviously the quantity, right? So tube current and exposure time increase the quantity of radiation, whereas tube potential, that is KVP, improves or increases the quality of radiation. Overall, as a result of these three factors, there will be increase in density. So density will increase as tube current, tube voltage and exposure time are increased, and vice versa, right? So these are directly proportional. Whereas option D, whether the X-ray film is in one packet or two packet, it doesn't matter, because see, you have these one packet films, right? So obviously you would have seen in your department also, you have one film in one packet. Sometimes you'll have packets which have two films. So two film packet produces two identical radiographs with same amount of exposure necessary to produce a single radiograph. So there won't be any alteration in density, right? So two film packet produces two identical radiographs. In fact, the packet contains two films, and these produce two identical radiographs with same amount of exposure necessary to produce a single radiograph, right? So option D is the appropriate answer. So density of radiograph is not influenced by a two film packet, whether it's a one film or two film packet, right? So let's move on to the final question of the day. So dash is used to restrict the size and shape of X-ray beam and to reduce patient exposure. So you have the question in the comments now, and I'll just post the options also. Option A, discrimination. Option B, collimation. Option C, filtration. Option D, barrier placement. So restriction of size and shape of X-ray beam to reduce patient exposure, right? Right. So it's called as collimation, right? So collimation, we have different types of collimators. We discussed all of this in e-classes previously, but we'll just try to summarize briefly the important points here. So collimator is a lead plate with a hole in the center, right? So we can have two types of collimators depending upon the shape, a rectangular collimator or a circular collimator. So rectangular collimator, just make a note of these points. Rectangular collimator restricts the size of X-ray beam to an area slightly larger than a size 2 intraoral film and significantly reduces patient exposure. So what would be the size of a size 2 intraoral film? We'll discuss the sizes of various films separately after this question, right? So you can just make a note of those points also. So we have a rectangular collimator which restricts the size of X-ray beam to an area that is slightly larger than a size 2 film, right? And the main aim of collimation is to reduce patient exposure. And we have another shape, another kind of collimator, that is circular collimator, based on the shape of the slit present in the lead plate. And this circular collimator produces a cone shaped beam that is 2.75 inches or 7 centimeters in diameter, which is considerably larger than size 2 intraoral film, right? So that's very important. So a circular collimator produces a cone shaped beam that is 2.75 inches or approximately 7 centimeter in diameter, considerably larger than the size of a size 2 intraoral film, right? So as you all rightly mentioned, collimation is used to restrict the size and shape of an X-ray beam and to reduce patient exposure. And along with that, I'll just recite the sizes of various films, right? I mean, it's given in various textbooks and also synopsis, and if you, I mean, if you couldn't really get it, you can just make a note of these points, right? So various sizes of intraoral periapical radiograph films, we have basically three sizes, right? It can be either IOPA or it can be either bite wing. So IOPA we can have, I mean, both we have three sizes, 0, 1 and 2, right? So zero size film is mainly used in children. One size film is mainly used in case of adults. In case of adults, anterior region, and two size film is mainly used in case of adults posterior region, right? It is still more large. So the size of zero size film is 22 into 35 millimeters. It is 22 into 35 millimeters. You have to memorize these values, right? Size 0, it is 22 and 35 mm used in children. Size 1, it is 24 into 40 mm in adults anteriorly. And size 2 is 31 into 41 mm, which is used in posterior aspects for adults, right? Size 0, 22 into 35. Size 1, 24 into 40. Size 2, 31 into 41 mm. So it is in millimeters. Just make a note of it. It's not centimeters, it is millimeters, right? And occlusal radiograph, the dimensions are 57 into 76 millimeters again. So it is in millimeters only. 57 into 76. And OPG, it's in range of 5 into 12 inches, or you can have another size of 6 into 12 inches. It is in inches, 5 into 12 inches or 6 into 12 inches. And various other extraoral radiographs apart from OPG sizes are 8 into 10 inches or 5 into 7 inches, right? So these are various sizes of intraoral periapical radiograph films. I mean, not only IOPA but also bite wing, but also occlusal, OPG and other panoramic radiographs, right? Just make a note of these points and try to memorize them. Just make a note of it, revise them periodically and repeatedly. You can just remember at least till the date of exam, right? So these are some of the multiple choice questions which I wanted to discuss in this live session. So if possible, depending upon the subject, we'll try to incorporate image based questions also in live sessions, right? And also we'll try to make more and more recorded videos regarding the same. So it is 6 a.m. in the morning, 46 minutes, right? So I hope this session is of some use for all of you. So I will see you again today evening, right? We'll see you again today evening with textbook discussion. Let's make it more interesting. So to make it more interesting, so I request you all to get a hard copy of a textbook rather than just listening to me, because the moment we're all used to it, right? Listening to lectures and all, we feel more bored and it will be more monotonous, right? So to overcome that, it's better if you have a notes along with, you can either have a notes or just get a hard copy of a textbook. It's better if you have a hard copy. I think you'll have, all of you have Phillips, right? Phillips 12th edition or 11th edition, right? So you can just underline and then we can simultaneously read and try to get important relevant points, if any, right? So the topic will be casting defects, and we'll see you today evening at around 7:30 p.m., right? So have a nice day. Once again, a very good morning. Have a great day ahead, right? Okay, bye. Manepali, no, I go for Phillips and or Craig, right? I'm not going to comment on that book which you asked, but go for these references, right? I mean, the values and all, if you can get from that book, you can absorb them, but go for these references as much as possible. Phillips as well as Craig, right? So bye everyone. Have a nice day. See you today evening, right? Keep smiling.